you see my presentation?
Yeah, we can see it properly. Thank you.
Thank you. Okay, my name is Aleksandra Borkowska and I am a student. I have the honor to represent the student scientific group of the Independent Laboratory of Pediatric and Adolescent Gynecology of the Medical University of Lublin. I would like to present you a case report of a 16-year-old girl with menstrual disorder due to panhypopituitarism. Okay, so sexual puberty in girls begins around the age of 10. Between 11 and 12 years of age, menarche occurs in them. For the first 2 years, the cycles are usually monophasic and non-ovulatory. This is the reason for the irregularity and variability of the duration of bleeding. This is part of the initial period of puberty for every woman. The problem arises when several years after menarche, girls continue to menstruate infrequently or even secondary stop. Drawing a clear line between when we are talking about physiology and when we are dealing with a complex problem is difficult. The causes should be sought in a disorder of the hypothalamic pituitary ovarian axis. In February 2021, a 16-year-old girl presented to the Pediatric Gynecology Outpatient Clinic. Menarche occurred in her age.
I'm sorry for interrupting. We still see the first slide only. Maybe.
Okay. Wait a minute. Maybe. Now?
Yeah, now it's well. Thank you.
Okay, thank you. So in February 2021, a 16-year-old girl presented to the Pediatric Gynecology Outpatient Clinic. Menarche occurred in her at the age of 11 years, and there were only 4 monthly bleeding. In the same year, her last menstrual period took place. Thereafter, scanty spotting occurred every few months, the last in October 2020. On physical examination, scanty body and intimate area hair and hypopigmentation of the nipple areolas were noted. This corresponded to stage 4 puberty. The uterus appeared hypoplastic. During the medical history, it became clear that the girl had been under the care of endocrinologist for several years because of hypothyroidism. Moreover, during the last few months, feature of the hypothyroidism appeared despite increasing the dose of levothyroxine to 100 micrograms. The girl also had hepatic steatosis and cardiac conduction disturbances, so she was also under the supervision of the gastrologist and cardiologist. Interestingly, the patient had lost over 20 kilograms of weight in the last 3 years. On genital ultrasound, the size of the uterus seemed normal. The right ovary also appears normal, while the left ovary was poorly visualized. In this case, due to the poor imaging condition for the ovaries, the reproductive organ ultrasound should be repeated. Due to the diagnosis of amenorrhea secundaria and hypogonadotrophic hypogonadism, the girl was referred to the Department of Endocrinology for future diagnostics. On examination, abnormalities in several hormonal axes subordinated to the pituitary gland were noted. X-ray evaluation of bone age was 14.5 years. And the whole clinical picture suggests panhypopituitarism. On examination, there were abnormalities in multiple hormonal axes subordinate to the pituitary. Hemogenic cystic protein-rich lesion is in the saddle region. Hypertensive, and the lesion causes displacement of the optic nerve junction, funiculus and hypothalamus, residual pituitary on the right side of the saddle without typical posterior lobe signal. Over time, the patient's symptoms were as follows. She was operated on the night of April 2021. In the postoperative course on day 1st, the vision of the right eye was restored. On day 6, she had a seizure. She was transferred to the Department of Endocrinology, where she was discharged on 28th of April 2021, diagnosed as a simple uremia, started desmopressin twice a day. Other drugs were maintained, hydrocortisone and levothyroxine. In histopathological examination, diagnosed raised pocket, cystic tissue sent with cylindrical squamous epithelium, partially squamous and normal pituitary tissue. The patient was referred to specialist clinics like endocrinology, gynecology, cardiology, and gastrology, and given appropriate treatment, levothyroxine, desmopressinum, and hydrocortisone. The underlying cause of menstrual dysfunction in this patient was multihormonal pituitary insufficiency, the symptoms of which manifested gradually, and the deterioration of the function of one of the pituitary hormonal axes, despite adequate treatment, should prompt future diagnostic investigation. The complex clinical problem requires interdisciplinary care of the girl. It is important to implement immediate causal treat and acquire topic hormonal substitution. Okay, thank you for your attention.